Okay, good morning. Hope you guys are doing well. We're going to talk about pediatric rehab today. We'll cover quickly just the neural development sequence. So at 6 weeks, typically infants will begin to develop control, head and neck control. Before that, you really need to support their head in all positions. Around 8 weeks, they can start tummy time and begin to develop those tummy muscles, and the whole core, the shoulder girdle, and everything can develop and strengthen during tummy time. Between 3 and 18 weeks, they begin rolling over. And now we're switching to months. Between 2 to 7 months, you can begin grasping. That's more of a fine motor thing. That's the only fine motor skill we have really listed. Around 7 months is a big age time where they begin sitting on their own, rocking on all fours, crawling, so really getting a lot more mobile. Around 8 months, they typically are able to do tall kneeling. Remember, that's up on your knees, and then half kneeling with one knee up. And then around 9 to 18 months, they begin to stand, cruise. That's where you're kind of standing at furniture and going sideways, back and forth, and walking. So that is kind of your first year of the motor milestones. These are kind of the big things. And just because a child doesn't reach exactly that age doesn't mean they're delayed. It has to be within, I think, outside of 2 standard deviations of the normal value. So it has to be, depending on, what motor skill it is, it would have to be significant delay in order to consider that child delayed. Now we're going to talk about some of the common things that you see and conditions that you see with pediatrics and how to treat those. So cerebral palsy is our first. It's a group of diagnoses with impaired motor control and posture. It's due to non-progressive or static encephalopathy, so fluid on the brain, so swelling on the brain, and it's caused by injury to an immature brain. So oftentimes it's trauma during birth. It could be in utero, something happened during the pregnancy or right after birth. Most of the time, it's kind of a lack of oxygen or, as we said, swelling on the brain itself. Some of the signs of cerebral palsy early on: feeding problems, issues latching or being able to maintain that sucking pattern. Hand preference. Typically, a child should use both hands equally until somewhere close to kindergarten. Most of their young years, they should use both hands equally. So if they show a significant hand preference at an early age, then you may start to think about cerebral palsy. Another thing is actually torticollis. If their head is kind of stuck towards one, looking towards one way, then they usually use that hand. They prefer that hand and they kind of ignore the other. So it could be other things as well, but a hand preference should not occur at a young age. Hypotonus followed by hypertonus. Remember, hypotonus or low tone involves like weakness, so it could be floppy limbs, low muscle tone, difficulty standing, instability, basically weakness in general. Hypertonia or increased tone is that spasticity, that static contraction, so it could cause stiffness in the muscles. High tone, muscle spasms, difficulty moving. Delayed integration of primitive reflexes. So all of us have reflexes and we go through them kind of in a pattern when they show up and when they disappear. And typically with cerebral palsy, they disappear or integrate, meaning you don't see them anymore at a later stage in development, later time frame. Neck hyperextension with shoulder retraction. So basically that's kind of like a reflex. Whenever they hyperextend, their shoulders will come straight back together, kind of a reflexive change to that change in head position. And most of the reflexes, as we learn some of those, are related to head position. And then unable to lift head while bearing weight on the forearms. Again, that's a reflex in itself. If they are bearing weight on the forearms that they cannot lift up against that, is also due to weakness. So often with low tone, their head will kind of be floppy. It'll just be hanging down and not able to stay in midline. And then unable to stabilize neck in sitting. So essentially those are primarily due to weakness, neck weakness. Some of the impairments that are associated with cerebral palsy. Muscle co-contractions, that's when the agonist and the antagonist are contracting at the same time. And so as you're trying to bend your arm and the biceps is contracting, the triceps is not relaxing, it's contracting too. So it's a rigid movement because the two muscles are fighting each other. Dependence on primitive reflexes. So rather than being able to actively extend your arm when you want to, you may have to turn your head in order to extend that arm, which is a reflex we'll learn later. Weakness, we already said. Sensory deficits. So oftentimes it's hypersensitivity, really sensitive to certain textures. And this includes textures in their mouth. So oftentimes when like that baby food texture, they'll just vomit as soon as it hits their mouth because it's just such a bad texture to them. So doing some sensitivity training is important, but also with their hands, touching things, and with their feet. Oftentimes the reason children walk up on their toes is not because they can't. I mean, almost always they can put their heel on the ground, at least initially, but their feet are sensitive and they don't want that feeling of that sensation of touching something. So they're trying to get as much of the foot off the ground as possible and touch the floor with as least amount of it as possible. So that's sensory deficit. So typically it's a hypersensitivity, and especially to certain textures like shaving cream or grass or things like that that are a little bit different texture. Balance deficits, postural instability, and then poor force generation. Of course, force generation comes with strength, and so if you have significant weakness, then you will have poor force generation. Some more impairments associated, poor motor control, so difficulty coordinating their movements. Fixate at end range for stability, so that's basically remember that posture we learned about where they're in full extension and their inguinal ligaments are tight. We learned about it with, well, in Rehab 1, we talked about people standing in that position for if they have a spinal cord injury. But basically, they're standing in a fully extended position so that their muscles have to do the least amount of work and their ligaments are able to really take over, and the tightness in the ligaments is what's given them stability because they don't have tightness from the muscles themselves. So that's what it means to fixate it in range to gain stability, especially in a standing posture. Sorry, early in the morning. Hope I didn't make you yawn. Muscle property changes, so the fiber type, the elasticity, and the trophic regulation. So sometimes remember the fiber type, like the fast twitch, slow twitch. The elasticity is how much they can extend. So if they have spasticity and it's contracted all the time, then more of those fibers are going to turn to those slow twitch because they don't need to be turned on quickly. They're just turned on all the time. They need that endurance. The other thing is the elasticity. If you're stuck in this contraction all the time, you're not going to be able to stretch it out. And then trophic regulation, I don't have any extra thing to add to that. Okay, deformities. Some of the common deformities are hip dysplasia. So remember, hip dysplasia occurs when the socket is not fully developed. So if it was fully developed, it would pretty much cover most of the head of the femur. But when it's underdeveloped, it only covers a portion. And so only a little bit of it is covered. Then when you move, it easily dislocates. So if all of it's covered, as you're moving, it's just kind of staying in that socket there. But as just a little bit of it is covered, every time it moves, it will dislocate. That's called hip dysplasia. So often you'll see them with those braces. You've seen the little babies with the braces that keep their legs and their hips in abduction and flexion. So it keeps it in this position where it's kind of in the center of the socket while the socket develops more around it. And then once the socket is more mature and more developed, then it should help keep the hip in place and keep it from dislocating. Visual impairments, oftentimes they'll need glasses. They may have even a visual field cut where there's a portion that's just completely blocked. And then increased energy expenditure. Of course, whenever your muscles are contracting at the same time, you will waste a lot of energy because you're working doubly hard in order to do every movement. So not only are you activating the biceps when you're bending, but also the triceps, and you have to activate the biceps extra to fight against the co-contraction on the antagonist muscle. So some of the treatments we do for cerebral palsy. Now with the treatments, I'm just going to go over categories, and we will talk more specifically in lab over what to do for the categories, and you'll start to notice patterns of most of the conditions you treat with the same categories. So bracing, if there's significant weakness, we can use braces. Of course, in this picture, she has some AFOs on to counteract against that dorsiflexion weakness, which this little girl is sweet and cute. I don't think she has cerebral palsy or weakness. Like, she already has tone in her tone in her legs and her arms. I think she's just a model they used for this device, but I couldn't find one that looked like they had significant weakness. But AFOs um, to keep the foot from dragging the ground. And then other braces just depend on if they have scoliosis, then you would certainly do back bracing. If they had even more weakness, you may even have a KAFO, up higher past the knee. I'm really sorry. Really sorry. Okay. Passive range of motion and stretching are some other treatments. Avoid overstretching tendons in children. So that's primarily talking about with like night splints or casting or things like that. So sometimes with cerebral palsy, as we mentioned, they'll walk on their toes, and then they get to a point where their heel cord or the Achilles tendon will shorten and not allow them to actually put their foot flat on the ground anymore. They're kind of stuck in plantar flexion. When that happens, oftentimes they'll recommend night splints or even serial casting, where they put the child in a cast that keeps them more towards dorsiflexion, and then every week or so often they change the cast to put them in more and more dorsiflexion. But if they put them in too much dorsiflexion, if they overstretch the heel cords or any tendon in general, if you overstretch it, it never gets to a place where it shortens again. So let's say I overstretch the Achilles tendon, and of course this is my foot. This is my foot. This is my calf muscle. If I overstretch the Achilles tendon here, that connects the calf muscle to the foot to allow plantar flexion, then I get good dorsiflexion, but whenever I contract the gastroc in order to plantar flex, there's nothing there pulling into plantar flexion because the Achilles tendon is overstretched and it's just hanging there loose. And so the muscle itself cannot pull on the bone in order to create the movement. So if you overstretch tendons, it can be detrimental to function, because then even though the muscle is intact, it could even be strong. It will not cause any movement because there's nothing anchoring the muscle to the bone in order to allow it to move the bone. Now, if they grow, then there's a chance that it may eventually come back. Function may come back, but if they're done growing, um, the tendon never shrinks back. So just be careful about that. Typically, that's more of a orthotist or something that would have to really watch. But if we're just doing basic stretches and range of motion and things, we're probably not going to get them to a place where we really overstretch because we're not holding it long enough to make those differences. But be careful in stretching the tendons. Then with gait training, typically we'll set them up with whatever assistive device they need. With cerebral palsy, it's very common for them to have this kind of retro walker that goes behind them. I have several pictures of it because almost every picture I found with somebody with cerebral palsy, they were walking with that. And then some of the treatments we can use for the spasticity are heat. Of course, heat can decrease your spasticity and help the muscles relax. Baclofen is an injection the medical doctor has to give. We don't give that ourselves. And it's like a relaxant to the muscle, so it counteracts that spasticity. It causes it to relax. They would have to get frequent shots of that baclofen. Some children have so much spasticity, they actually put a baclofen pump in. So it's a pump that's implanted under the skin, and it shoots out a certain amount of baclofen every few days or so. And and gives them kind of that constant stream of baclofen to relax their muscles. I had one patient who was an adult and he had a baclofen pump. He had cerebral palsy, and he would, once he got it refilled, the baclofen pump, everything would start to, his muscles and things would start to relax and he would start to move better. But as it came time to go get the pump refilled, I guess it was running out. Then he would stiffen up big time. There was a huge difference. I could tell when he got low on baclofen. So that's something to pay attention to. Now, sometimes the tightness can help increase their stability, and if they put too much baclofen or too many shots or whatnot, then they get less stable. So you can watch for that too if they get kind of loose and that spasticity was helping them have some type of stability since they have so much weakness. Breaking reflex patterns. So there's several things you can do to break the reflex if they're stuck in a reflex. Sometimes that will cause their tightness to increase as well. So, for example, there's a reflex that as their head's in an extended position, their arms are extended as well. And if you're trying to do passive range of motion and their arms are kind of stuck in this rigid extension, make sure that their head is in a neutral position. Ideally, to counteract reflexes, you put their head in a neutral position. But sometimes you can also put it in the opposite. So you can put it in flexion, and they'll go more towards flexion with their arms. Or to counteract any of the reflexes from kicking in, you could just put them in a neutral position. So we'll go over more things to help you break reflexes at the end of this PowerPoint. More treatment for cerebral palsy, prolonged stretching, so night splints and casting I already talked about. Avoiding contractures, whatever you, oh, this is a night splint, by the way, if you're wondering what a night splint is. Avoiding contractures, so making sure that they're continuing to educate caregivers on passive range of motion, on stretching and things at home as well, on positioning. Weight-bearing exercises, that's great for the connections and the pathways to the brain, and also proprioceptive, the proprioceptive feedback, but also for developing strong bones. Then strengthening the hip stabilizers, of course, if they have hip dysplasia, then they're more likely to dislocate their hip anyway. So make sure that you're doing some hip strengthening exercises to kind of counteract that and increase their hip stability. Aquatic therapy is great, especially depending on how involved. I'm sorry, I'm dying in here. If the child is able to walk in things, that's great, but there's some that have diplegia or quadriplegia or hemiplegia or different patterns depending on what part of the brain is affected. And so, of course, with those kids, aquatic therapy is even more helpful with kids like that because it can give them some movement that they wouldn't have otherwise. Balance exercises and training, whether it's sitting balance or standing balance, getting that core a little bit more stable. Rolling, sitting balance, prone tolerance. I have this picture of the girl laying on her stomach because I found with my children as I was doing therapy that almost all of them could still benefit from tummy time. So a lot of our children with sensory disorders or with sensory processing issues, whether it's from cerebral palsy or any other autism, anything, a lot of them don't like tummy time. They hate tummy time and they will cry and freak out. And because of that, oftentimes they skip crawling. They'll go straight to walking because they never like to be on their stomach. They don't end up strengthening themselves on that in that position. But what happens, crawling is really important because crawling actually strengthens your core, it strengthens your shoulder girdle, it strengthens your hips. All of those kind of trunk stabilizers and things are strengthened in that quadruped position, and especially as you're freeing an arm or a leg to crawl. And so the other thing it does too is it's that deep pressure through your joints that gives you increased feedback. And so it helps you know where your hands are in space. And so crawling and tummy time are huge. And even if they're older, if it's, a child that's way past crawling years, having them on their tummy to do some type of functional task is great for head and neck strength for and head control and for core strength. So I had children that were, I remember one specifically was in fourth grade that could not hold her head up in prone. And we kept doing prone, trying to get her to just lay on her stomach and look up a little bit. And then we progressed and progressed to where she could prop up on her elbows and then she could push up and she could keep her head up in that position. Eventually, she got stronger and stronger. So just because they're not a baby anymore doesn't mean they can't benefit from tummy time. And then one more thing to mention about cerebral palsy is Gage's 5 problem areas. So these are problem areas with gait, the common problem areas that you see in a child or an adult with cerebral palsy, things that they have difficulty doing with their gait. So stability during their stance phase, of course, due to weakness and maybe even changes in how they're planting their foot if they're walking on their toes. Foot clearance and swing phase. If you have weak dorsiflexors, then your foot is going to drop and make it difficult to clear the ground. Pre-positioning for stance phase during terminal stance. So pre-positioning for stance phase during terminal stance. So getting their foot in a good position, of course, ideally, they would do a heel strike and then land with their foot kind of in more of a neutral position. But if they have a lot of weakness, they might over supinate and kind of step on the side of their foot, even over pronate, let their foot cave in towards the middle. And so that's what we're kind of talking about for pre-positioning the foot for stance phase during terminal swing, getting the foot in a good position so when it hits the ground, it's able to accept the weight versus just caving in towards one side or the other. Adequate step length, stepping long enough steps, and then energy conservation. If your muscles are co-contracting, it's going to be hard to conserve energy. You're going to be tired and fatigued very easily. And our gait training for patients with cerebral palsy pretty much focus on these 5 areas, 5 problem areas. So we work on taking longer steps, clearing the ground, putting your foot in a good position, stability, and then energy conservation. Ideally, if you can loosen the muscles up enough, then you'll kind of counteract some of those co-contractions. Okay, so hypotonia, low tone, in general, we see this with cerebral palsy, but we actually see this all the time with so many different disorders. So just being familiar with that is key. So low tone, so that's just basically significant weakness all around, generalized weakness. And as I mentioned earlier, not being able to hold their head up in prone, this is kind of what it looks like. This is one of the tests to see if a child has low tone, pick them up in a prone position, and if their head is kind of dragging and not at least in line with their torso, then that tells you there's some tone there. And then as you grab their hands and try to pull them to a seated position, I have to look at the exact time frame, but within definitely by 6 weeks when they have head control, they should be able to at least keep their head aligned with their trunk. And then after that, they can't even tuck their chin to give them a little bit more oomph to go forward. But with low tone, they're not able to do that because of the significant neck weakness. So the main thing with low tone is weakness, but there's also decreased resistance to passive range of motion. So they feel kind of floppy as you're going through and doing. There's a certain amount of natural resistance our body has to movement, and theirs does not. It just flops around, kind of like a baby when they're asleep, how you can lift their arm up and it just flops. It kind of feels like that. It's just floppy. There's no resistance to your movements. Hypermobile joints, typically when you have low tone, you're also hypermobile. So able, what some people will call double jointed, able to move past the normal range. Ligament laxity, which is what causes you to have hypermobile joints whenever your ligaments are not stabilizing as much as they should be. Low activity tolerance, basically due to muscle weakness. They only tolerate a little bit of activity. Sometimes you'll see them in the middle of treatment yawning or kind of starting to fall asleep a little bit because they've already hit their limit at activity tolerance and their body is ready to recover. Developmental delay getting those motor milestones, reaching those motor milestones we talked about earlier. Difficulty with head, neck, and jaw control. The reason jaw control really matters to us is eating, feeding. So sometimes they'll have also kind of a weak latch or poor suck, and so it's difficult for them to eat. And even once they start eating more foods and different textures, still difficulty controlling those movements and having the stamina to eat enough to really gain the weight they need to. And then difficulty feeding and sucking, as I mentioned. All right, treating people with low tone. So, some of the main things that we want to do are strengthening. We primarily want to focus on strengthening, but the main areas are kind of the neck and core muscles, getting and the more proximal muscles, the stabilizing muscles, so the shoulder girdle, the hip girdle, all that. So core strengthening and stability, as you see, prone, crawling to activities, crouching down, anything that bears weight through the arms and legs is wonderful for the kids in strengthening that. Endurance activities, even just going for long walks. Sometimes even I would take some of these kids to just play at a park because they were motivated to do it. They wanted to play, but they couldn't sit on the swing very long at all, or they couldn't actually have the endurance to climb all the way up the slide, or some of the things they were motivated to do, they didn't have the endurance to do. Deep pressure or joint compressions. So grabbing, I hate, I always try to show myself, but you need one hand here and one hand here and push together in joint compressions. And you can use those joint compressions to prepare for tasks. So you can do joint compressions of the legs, kind of pushing them together. There's another word for it as well, besides compressions. I saw it in the board prep book, and I wanted to start calling it this approximation. Joint approximation, when you're pushing the joint together. That's another word for joint compressions. And I'm actually going to add it to the thing so I don't forget to say next time. Okay, so deep pressure, joint compressions, joint approximations, all the same thing. It helps our brain kind of know where things are. We have so many nerve endings and so get so much feedback from the joints, from that joint compression, that when we compress, then our brain is more alert and aware of those areas, and then we can do more with them. So we had it was a patient that you would say throw a ball, and she would just literally just drop it out of her hand. She was trying to throw it, but she would just drop it like that. And then we would have her crawl around on the ground and throw it, and she could throw it about 6 feet at that point. The first time it didn't even go 2 inches, it just fell. But after that, she could throw it 6 feet. And it would last for maybe 5 minutes, and we would have to have her crawl again for her to be able to throw it, again that far. But that deep pressure when she would crawl around made such a difference in her ability to perform any type of upper extremity task. Prone tolerance, laying on the stomach and doing something they're motivated to do. There were some students, or I keep calling them students, patients, that weren't motivated to do anything except watch TV. And sometimes we would say, okay, well, you can watch this, 2-minute video or this 5-minute YouTube thing if you're on your stomach. And they would be really motivated to hold their head up to watch that for a few minutes while they were on the stomach. And then generalized strengthening. Anything that you can make into a strengthening activity. We did a lot of obstacle courses. I'm losing my words today. We did a lot of obstacle courses because most kids are motivated to do those. Here it looks like they're doing some type of a leapfrog, hopscotch type game. And anything like that is typically pretty motivating for kids. So remember, with kids, you have to make it fun and motivating. You can't just say, go over there and do 30 bicep curls. You have to say, pick up this big toy or whatever, move it over here, help me get this ready, climb up this. And you have to really make it fun. And for me, I'm not very good with imagination and making it like playful that way. And so I would have to just set up something that they were motivated to do, like an obstacle course, or go to a playground and, have them run over this way, or sometimes even having other children in there with them. For example, if they had a sibling, maybe having the sibling doing something. Oh, that was super motivating to children. And another example is swings, different types of swings. I told you all about the platform swing. There's bolster swings. I actually have it in the next picture. Platform swings, bolster swings, even like step type of swings where they can, squat or tall kneel. That's tall kneeling there. Tall kneeling is a great position for kids with low tone because it helps strengthen the core and the hips as well. And the bolster swing is great. It's kind of like riding a horse. You have to really have some good strength in the hips and in the core to hang on tight. And one of the ways we would have them do it too is hug it, like, hug it around and try and hold on without going upside down and falling off. And they were typically really motivated to do that. So one of the things we need to focus on while we're treating patients with hypotonia is increasing their level of alertness or arousal. So we have this internal motor, and the motor can run kind of low, and that's when you're kind of drowsy and yawning like I was earlier, ready to fall asleep. Or your motor could run really high where you're just all over the place and can't focus on one task. And depending on the condition, most uh, kids have some, kind of when they lean towards. They typically are kind of low, or they're typically a little bit too high. With low tone, oftentimes they're a little bit on the low end. With autism, oftentimes they're a little bit on the high end. And to get somebody in their uh, best state, best condition, their engine needs to be right in that midpoint. It doesn't need to be too high or too low. We function best. Think about in class. If you are, right at your good functioning level, right in the middle, you can hear and you can learn and you can focus. But if you're ready to fall asleep, like you might be right now, you can't learn anything. Or if you have 30 things on your mind and you're thinking, I need to go to the grocery store, I need to do this, I need to run here, I forgot about that, I have this assignment due, and all those things are fighting for your attention, you can't focus enough to listen to what I'm saying. And so kids are the same way. And even with the motor skills, If they're too high or too low, they're going to struggle with focusing and with really performing at their best level. So, one of our jobs is kind of getting them to the right level of alertness. And the thing is, with sensory activities, sensory bends, water activities, sand activities, swinging, rotational activities, spinning or rolling, the great thing about these is they can increase your alertness level if you're too low. So if you're about to fall asleep and somebody starts rocking your seat, you're going to kind of wake up and increase your alertness level. Or they can also decrease your alertness level if you're too high. Think about if you are, or even a child. A child is wah, 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 crazy and crying, and you rock them to sleep. That rocking motion can help decrease their alertness level if they're too high. So the great thing about swings and that vestibular input and that sensory input is it can help them get to that right level of alertness. And once they're there, oftentimes they may say a word. We'll see with hippotherapy. I'm sure she will mention later this week that oftentimes when people are at their right level of alertness, which hippotherapy can help do, they'll say their first word, or they'll do a movement they haven't done, or a task that they've never been able to perform. So getting them there is key. Other things we do for hypotonia: bracing to help. Remember, if it's weak, strengthen it. If it's unstable, stabilize it. If it is tight, stretch it. There's one more I usually use. It's weak, strengthen it. If it's tight, stretch it. Those are the main things. That's what we do as treatment, as therapists. So I think there's one more I usually say, but y'all have to remind me in class because my brain's somewhere else. I'm not at my right level of alertness, evidently. And then sitting balance is great for core control and for independence and stability. The quadruped position is wonderful, as I mentioned earlier, crawling and things, even just staying in that position and rocking or freeing a hand to grab something is wonderful strengthening. Gait training, getting them to take larger steps or to clear the floor, getting them to weight shift side to side, forward and backward. Weight-bearing activities, especially through the arms, and then postural training, so sitting up straight. Sometimes you can use a mirror, and depending on their sensory input, they may or may not have correct. I've seen a lot of kids that look at a mirror and don't necessarily recognize themselves or don't necessarily see what you're seeing. You're saying they're all slumped to the side and they're looking in the mirror, and you say, "Now sit up straight. Can you see if you're sitting up straight?" "Yeah." "Are you sitting up straight?" "Yeah." "Now, do you see how you're slumped to one side?" "No." So I've seen that happen a lot. That their awareness is not always right at where we would want them to be. So you have to kind of get creative in getting them to sit up right or maintain a good posture alignment. So we're going to switch for just a second and talk about some of the reflexes I mentioned. ATNR is our first one, asymmetrical tonic neck reflex. Turn your head one way, the arm you're looking towards is straightening, the other arm is bent up. We call it the fencing reflex because it looks like you're ready to fight somebody with a little fencing thing. I don't know how you fence, but you got a little stick in your hand. Okay, so as you turn one way, that arm straightens, the other arm bends, turn the other way, that arm straightens, and the other arm bends. And that is ATNR. ATNR. STNR, or symmetrical tonic neck reflex, is when the head flexes, the arms flex, but the legs extend. So the legs would be more towards extension here than they really are, but and then as the head extends, the arms extend and the knees flex, as in the second picture. So that's STNR, symmetrical tonic neck reflexes. The first one's asymmetrical because one side's doing one thing, the other side's doing the other thing. This one is symmetrical because both sides are doing the same thing. It's just the upper extremity is doing one thing, the lower is doing another. So with the symmetrical, both sides are doing the same thing. So as you flex your head, your arms are doing the same thing as your head and the same thing on both sides. They're flexing, but the legs are extending. As you extend your head, your both arms extend, but your legs flex. And then tonic labyrinthine reflexes, everything's doing the same thing. So as your head extends, the arms and legs extend. As your head flexes, the arms and legs flex. So everything's doing the same thing. So ATNR, asymmetrical, one arm's bent, other arm's straight as your head turns. Symmetrical, as the head flexes, the arms flex and the legs are straight. As the head extends, the arms extend and the legs are flexed. Tonic labyrinthine, or TLR reflex, is as the head extends, everything is in extension. As the head flexes, everything is in flexion, like the fetal position. Okay, let's talk about a few of the more of the positions that help you break reflexive patterns. So why would you want to break a reflex? Well, here's an example. We had a young guy, he was in first grade, that was playing basketball with us for the Special Olympics, and he could not throw the ball without stomping both legs. So you would say throw, and as he threw the ball, both legs would just automatically jump, and he couldn't do it. And then we had him crawl around on the floor, and then he threw the ball without jumping, without flexing both of his legs or stomping both of his legs. And after a few minutes, it came back. He started doing it again, and we had him crawl around again. So it's amazing how some of these reflexes, it's like you can't break away from them. You cannot have only one arm doing something. If your head's in one position, both arms are in that position, and you can't break away from that pattern. But whenever you do some of these positions to help you break through the reflex, then you're able to free the arm to do the functional task that you wanted to do. That's why we want to break through the reflexes for function. So prone and prone extension are great for breaking through reflexes. Side lying or side sitting can be helpful. Here's side sitting there with a arm out. Long sitting or supine could be helpful. Quadruped to me is one of the most helpful, and one of the things that I had an OT showed me in quadruped is having them do quadruped and do their head up and down and do their head left and right. And it was amazing how that broke through reflexes. So that's something you could try as well. They're on all fours and they're doing their head up and down, and then they're kind of rotating, shaking their head no. And then they're able to get up and break through some of those patterns and do more functional activities. Opposite arm and leg extension, especially in quadruped, is good. Good luck getting them there. That's a kind of a difficult thing to do, but if you can, that'd be great. Squatting, half kneeling, tall kneeling, and standing. So remember, half kneeling is pictured right here. Full kneeling or tall kneeling, both legs would be down like the bottom leg. And all of these can be used to break through patterns. So we're going to switch gears here and talk about muscular dystrophy. So muscular dystrophy is a group of diseases that involve progressive muscle weakness. It's due to a genetic mutation that decreases your production of a protein that's needed to maintain healthy muscle growth. So muscular dystrophy, they're lacking a protein that's needed to keep their muscles healthy, and so their muscles begin to break down and lose mass, lose strength, atrophy. It typically begins in early childhood. There's so many different types, but some of the types begin between ages 2 and 5, and some show up in teenage or adult years. It's hereditary, and there's over 30 types of muscle dystrophy. I had a patient when I first started in pediatrics, and I really wasn't familiar with some of the conditions like I should have been, because I had been working in adult PT for a long time. I had a parent that had just started bringing her son to therapy, and she was just telling me about him. He was seeing another therapist, and she was saying It's the strangest thing. He was doing everything. He was so active and all this, and all of a sudden, after his fourth birthday, he just started wanting to sit down a lot, and he would get tired and start crying because he was tired. And she was like, it's like he was meeting all of his milestones, and now he's regressing. I just don't understand. The doctors can't tell me what's going on. And she was like, he's getting weak. And then you could see when I saw him, you could see the way he walked. He walked on his toes, and his calf muscles were built up and stuff. These are kind of some of the signs of muscular dystrophy we'll learn on the next slide. And I believe, now I only saw him that one time. I didn't end up working. I switched to a different clinic, but and I believe he was likely diagnosed with muscular dystrophy. But at the time, I was just baffled. I was like, what in the world is this? And now learning about muscular dystrophy again, it reminded me of that little boy, I'm sure, was later diagnosed with that, unfortunately. But some of the signs, so frequent falls, muscle pain and stiffness, toe walking with enlarged gastrocs. So although your muscles are weakening and atrophying, in the gastroc specifically, there's being fat deposits are being, so fatty tissue is being replaced in or placed down in place of the muscles. And so often you'll see them with really big calf muscles, but it's not the muscle itself. It's really just fat deposits in the area. So they're still weak, but they will often walk on their toes. They'll have difficulty standing or sitting, trouble running, jumping, poor coordination. There may be some learning disabilities involved. They'll often have poor posture, possibly even scoliosis, and then scapular winging. Scapular winging happens with weakness in the serratus anterior. Remember serratus anterior? SALT, it's innervated by the long thoracic nerve. That's just a bonus. And it does that punching forward motion, like a push-up plus is how you could strengthen it. But if it's weak, then you'll see the scapula just kind of wing out and stick out in the back. So all of these are mainly related to weakness, generalized weakness. Now, the heel cord may become tight after walking on the toes for a while, but all this is related to weakness primarily. This is just a list of some of the common types. So Duchenne's is how I say it, but it might be Duchenne's. I've always heard it Duchenne's muscle dystrophy, or Becker's muscular dystrophy are two of the common types. So this gray part shows the portions that are the weakest with that type of muscular dystrophy. So the neck, the arms, the upper legs, the calves are primarily the weakest in these two types. So A goes with A. And then Emery-Dreyfus is this one right here, B, and it's primarily the arms and legs. Limb, girdle, kind of proximal arms and legs. Facioscapulohumeral, so the face muscles themselves, and then kind of the shoulder girdle and the calves. Distal is mainly the hands and feet, and then oculopharyngeal affects your eyes, it affects your neck and your swallowing muscles, and then those proximal muscles of the arms and legs. Now, this is just a few of the types, and like I said, there's over 30, so it could affect various muscles, just depending on what they have. With Duchenne's, this is one of the most common. It is progressive weakness. There's an absence of a gene that's necessary to produce that protein that we talked about that allows muscles to maintain their health and strength. So muscle fibers get destroyed and are replaced with fat and connective tissue. So that's what we were talking about with the kind of enlarged gastroc. It's not muscle mass, it's just fatty tissue replacing the muscle. Symptoms typically show up between ages 2 and 5. It's hereditary, and it's due to a recessive gene on the X chromosome. So if you're into that genetics of seeing who passes along what, you can kind of figure those out. It's the X chromosome. And then females can carry it, but it only displays in males. Life expectancy is less than 25 years. So it's progressive. It is going to get worse. If they're doing therapy, it's just to maintain and slow the progression of the disease, but they are not going to improve. They're going to get worse. Some of the ways that muscular dystrophy are diagnosed, they can do enzyme testing, an EMG, genetic testing, muscle biopsy, and then heart and lung monitoring. Okay, some of the things that we do as physical therapists to treat muscular dystrophy. Again, it's not treating the disorder, it's just slowing the progression of the disease. But we would do very low impact aerobic or endurance training, so walking, stair training. Aquatic therapy is great because it's very low impact, but it does strengthening and maintaining good alignment and things throughout. If you are doing like resistance training, make sure you're doing low weight and more high repetitions. So more for endurance than for, muscle mass and bodybuilding type, but very low weight, very low resistance. You can do range of motion and breathing exercises, make recommendations and helping set up the proper assistive device or braces that they may need. And then any type of functional mobility training you can do as well. Some of the things that we tell their caregivers are make sure they avoid placing stress on the joints to avoid dislocating them. Once there's significant weakness, if you pull on the arm to, make your child walk faster, you may actually dislocate their shoulder. You have to be very careful, or even their radial head. Remember that nursemaid's elbow? And then avoid overstretching, especially with bracing in the heel cord. Remember, we talked about those night splints or serial casting. If they're placed on too tight, they can overstretch, and there's no coming back from overstretching a tendon. So be very careful with that. Support trunk in the upright position in order to assist with the breathing. Of course, it's more important with scoliosis. Put them as upright as possible. But the main thing is getting them to where they're able to breathe well and their lung capacity is able to expand and contract as needed. And then use your weight. So this is just talking about biomechanics in order to avoid injuring yourself during handling, like if you're transferring the patient, just teaching them proper technique and body mechanics to be able to do that without hurting themselves. All right, so with the documentation, it's really important with muscular dystrophy because our goals are not really for improvement, but maintenance or decreasing progress. So data collection is important, and saying things like patient, is able to walk 5 feet as previously and has not declined in duration or does not need to increase rest breaks, or even saying you can show progress with like they're getting more independent with their home exercise program, or the caregiver's more independent with transfers. There's a lot of things you can show progress with their independence level in dealing with what they already have, but you're not going to show a lot of progress as far as they increase their muscle strength or they increased their endurance or whatever. Most of that is going to be maintenance. So just be careful how you word things. But be as concrete as possible, record their walking distance, the number of minutes they were able to stand or do an exercise, the reps, the amount of time to recover. All of that stuff is key in being able to continue treating a patient. You can use charts, graphs, and spreadsheets. Typically, those are used in school-based therapy. Outpatient clinics don't use them quite as much, but that's one way to show that they're not declining as quickly as they would otherwise. Some of the secondary complications that come with having muscular dystrophy: contractures. So we, of course, want to avoid those. Passive range of motion and stretching is how we try to avoid those. Respiratory issues, if you are kind of stuck in a position and you're weak and poor posture, all that can kind of make it hard for the lungs to expand for good deep breaths. Scoliosis, eventually that weakness that can begin to kind of cave towards one side. Heart problems, remember the heart itself is a muscle. Feeding problems, difficulty chewing and swallowing, having the endurance to do as much as they need to there, and difficulty walking. With weakness, you're going to have trouble walking and may eventually lose that capability. Eventually, they may develop even deformities based on the contractures because of the weakness. Considerations: do not overwork the muscles. That will actually make the condition worse rather than better, because if you break down, remember when we're building up muscle, we first break it down in order to build it up. So whenever you're doing a lot of resistance training, that's what you're doing, breaking down the muscles. But if already their muscles are breaking down and don't have the ability to build themselves back up, you don't want to break them down at all. So don't overwork the muscles. Allow them to have frequent rest breaks. If they need a rest break, let them rest as long as they need, and give them more time to recover. And then expect there to be good days and bad days. Just because they declined one day doesn't mean that they're actually declining overall. It could just be a bad day. Expect that with this condition. Exercise progressions, we need to progress them. This is, again, talking about people with muscular dystrophy. Progress them slowly, and typically you progress one exercise at a time. You're not doing overall full body progression. The treatment goal is to slow the progression of the disease, not to build muscle, not to increase strength. You may progress to less rest breaks. You may say now the rest breaks are shorter or less frequent, and that's a way of showing progress as well. And if you progress too quickly, remember you're actually going to overwork the muscles, which is going to cause their condition to decline, and you can't get that back. So be very careful with that. Switching gears, we're going to talk about some genetic disorders. A genetic disorder is an inherited medical condition. You got it from a parent. It's caused by an abnormality in the genome. The genome is your genetic makeup. It includes your DNA and your chromosomes. All those things are in your genome. And so an abnormality in that genome is what causes a genetic disorder. It may be inherited from parents, but it also may be caused by a sporadic mutation of a gene. Just because you have it doesn't mean anybody up the line has it, certain ones. Newborn screening typically detects a lot of the most common genetic disorders, but there's over 2,000 genetic tests that are available for specific disorders. So not all of them are performed in the newborn screening, so some of them may be missed. Testing is important in diagnosis and in determining what type and how much medication is needed for a specific diagnosis. Some of the common ones you may be familiar with: Down syndrome, Huntington's disease, Fragile X syndrome, sickle cell anemia, hemophilia, Marfan syndrome, and Turner syndrome. These are all common genetic disorders, but like I said, there's over 2,000 tests for types of genetic disorders, and there's some that are diagnosed by ruling out others. So there's a lot of different types. Switching gears again, spina bifida. This is a condition where the neural tube does not fully develop or close. Remember, the neural tube is kind of your starting point in the womb. You start kind of as this neural tube. It's kind of like a round circle, and it grows and then closes on the end, and then your head and your body develops from that. So the spina bifida is an issue with it closing or fully developing. It can cause defects in the spinal cord. This is ridiculous, I'm sorry. And in the vertebral columns. It can be mild to severe. One of the most severe types of spina bifida is called myelomeningocele, and that is where the nerves actually form a bundle outside of the body. Okay, so there could be just a fluid sac, which is just called meningocele, or there could be a fluid sac with nerves protruding out of the body, which is myelomeningocele. Um, and with spina bifida in general, it causes weakness, decreased sensation below the area that's affected, and there could be that fluid sac. Now, it could be at the bottom of the neural tube, which would be the bottom of the spinal cord, spinal column, or it could even be at the top. So it could, you could have a bulge up at the top. Also, if for people, one of the signs that you have a gene that could cause, that you're genetically predisposed to spina bifida is a stork bite is what they called. I actually have one. I have one here at the top of my head. I have one at the top of my neck and at the base, kind of the top of the base of the spine. And that like red discoloration, or it could be kind of a brown spotty discoloration, is a sign that you may be predisposed. And other signs are like a significant tuft of hair there at that bottom, like if the baby is born with a hair patch at the bottom of the spine or even at the top. And another is like a pinhole. So my first few children were born with like a little indention kind of at the top of the butt crack, and they kind of checked it and did some testing just to make sure they didn't have spina bifida, and they didn't. But my last child was born with like a pinhole, and they had to check him several times because they were more concerned about that, there being an opening or an entrance or maybe leaking out spinal fluid, and it wasn't, thank the Lord, but there was that pinhole. And like I said, I have the redness and the discoloration at all the points. And I didn't realize until I was in school that that was a sign of spina bifida. Nobody ever told my mom or anything. Then when my kids were born, I was more concerned because they had kind of the next generation of the sign, the actual, indention or hole. But a cousin of mine was born. I was just talking to her about it. Her little daughter was born, and she had the big hair patch and the pinhole. And she said they were so concerned about her that she had to have testing done like every month for the first few months of her life. And then just last week, I found out that another cousin had a child with spina bifida that did, was confirmed to have it. So it's all on one side of the family, that we're figuring out where, kind of it's running through the pathways, but evidently it does run in our family. And we're starting to see, the next generation of kids having signs of it. So, those are some signs, that you may notice in your own family or your children, or have seen that in somebody else, that spina bifida runs in that genetic pool. And then the last slide for this lecture, but we have one more, or for this PowerPoint, we have one more PowerPoint to cover, so I'm sorry if I give you false hopes, is the Chiari malformation. Now, with the Chiari malformation, that is where brain matter is actually bulging into the spinal column. So it could be because the skull is either too small or it's misshapen, but it's forcing brain matter to bulge into the spinal column. Typically, it's present at birth, but there's times where it's not caught at birth because they don't just give, x-rays and MRIs to everybody. They only do it if they feel that there's an issue. And some of the symptoms are headache, neck pain, muscle weakness, vomiting, dizziness, balance deficits, poor coordination, hearing problems. Tinnitus is that ringing in the ears. All of those could be related to the cerebellum pushing through the spinal column, and there being pressure on the spinal column, but also on the cerebellum. All right, so we're going to switch gears. It's a lot shorter lecture, but these are some of the common pediatric disorders that I saw when I was treating patients that weren't necessarily covered in some of the other materials. So I just wanted to touch on them quickly so that you're familiar if you do have a patient with one of these disorders. So the first one, you should probably all be familiar with, autism spectrum disorder. They're getting more and more common. And used to, there was autism and there was Asperger's syndrome. And so some of my adult clients are diagnosed with Asperger's syndrome, but now they're all considered under autism spectrum disorder. And there's just various levels of on the spectrum, depending on how they present. So it's a neurological and developmental disorder with a wide variety of symptoms and clinical presentations, including characteristics of behavior patterns, difficulty with social interactions. So there's a huge variety of symptoms. Honestly, there's difficulty interacting. There is we see a lot of hypotonia, the low tone and generalized weakness with children with autism. We also see a lot of sensory processing issues. So the hypersensitivity, not liking certain food textures or textures that their hands or feet come in contact with, or hyposensitivity. You'll see they're not getting enough sensory input, and these are the headbangers that will hit their head on things or that will flap their hands, especially in front of their eyes, or that rock. So these type of behaviors are children that are not getting enough sensory input from their limbs, and so their brain is constantly wondering, where is my body? And they have to actually do something physical, whether it's rocking or flapping of the hands, something of that nature, in order to give their brain input on where their body is. So that's part of a sensory processing issue that's common with autism. And they're doing those behaviors naturally to increase that input into their brain. One of the things that I found interesting, I never had heard of, is people that don't get enough visual, like they are low on the input, they need extra input. We call them sensory seekers, is what we call them. I saw it with people with autism, and I saw it with people with agenesis of the corpus callosum, which we'll come to later in this lecture. But where they weren't getting enough input, and so they would do things constantly to give themselves input. So like one guy would run into things constantly. He would just jump into walls and hit into kids because he needed that extra input on his body. But he also would constantly pick up, like on the playground, it was hard for him to play with other kids because he would go and get mulch and he would bring it right in front of his eyes and just drop it. And he just loved that input that he got. And they called it visual stimming, that he was getting visually stimulated by that. And that's all he would want to do. He would just pick something up and drop it right at his eye level and just do it over and over because he needed that extra input. So it's amazing some of the habits that they learn to do to kind of cope with what their brain needs or the input that they need or the overstimulation that their brain has. It's difficult to determine the cause of autism. I know that there's a lot of speculation as far as what we're putting into our bodies, whether it's food or whether it's vaccines or other type of chemicals that we're putting into our body. But there's a lot of speculation. There was a research study that, connected autism with vaccines, and there's a lot among the medical community. It's really, that research was not accepted. They said there was a lot of flaws in the research, and that that man actually got I don't know what it's called. I want to call it disbarred, but it's not. It's he lost his medical license to practice because of the research. However, I will say, with my personal experience, most of the patients that I had that were diagnosed with autism, which was a big part of my caseload, their parents could tell you which shot they noticed their child changing. They would say they were talking, they were making eye contact, they were hitting their milestones, and then at this shot, within they spiked a fever. Within 24 hours, they were a different kid. And so, just something to be aware of. I only had one parent that did not claim that whose child, both of her children had autism, but all my other parents could tell you kind of where they started noticing symptoms. But another common thing that we noticed was a lot of the parents who had taken the very intense acne medications like Accutane, like those types of medications that they say don't get pregnant while you're taking them. We noticed that a lot of times that was another common thing. This is just things I'm noticing. I'm not making connections, but um, you know, between all the crap we eat in our diet and all the chemicals we put in our body, whether it's through medication or through whatever other things, who knows what is causing. But I definitely think that it could be related to some of the things we are putting in our body, especially with the experience I had. So just kind of a heads up. But um, there is not a genetic test to determine if somebody has autism. There's not a blood work or anything that can be done. They base the diagnosis on symptoms. So they'll test a child, or they will look at a child and consider what symptoms they have, and then determine that diagnosis um, based on just the symptoms alone. All right, so some of the symptoms, delayed motor milestones, not meeting their milestones, speech delay, um, feeding problems, poor eye contact, low imaginative play, not being able to relate to their peers and imagine and play that way. And if they have a car in their hand, rather than saying vroom and pretending with the car, they might just line up the cars, or with blocks rather than building and breaking them down, they might just line them up. That's kind of a common thing to see with autism. And then low awareness of social cues. One of the ones I noticed often was personal space. A lot of my kids I had with autism were not aware of personal space. They would come right up in your personal space. Or, if they were saying something that might be offensive, like maybe, one of them might say, well, you look fat in that, or, that uh, shirt you're wearing not very, doesn't look good on you. Something like that. Not picking up on that might hurt somebody's feelings, or the social cue, or even if I said a comment back like, well, that wasn't very nice, or something, not even, picking up on that. So there's different um, things like that, but are they're different for each child, just based on their symptoms. So um, these are some of the symptoms. It can really be a wide variety. Sensory processing is one of the main things that I also saw, them having difficulty with certain sensations and difficulty processing that information. Why would a PT see somebody with autism spectrum disorder? Well, they have low spatial awareness. Oftentimes they'll bump into objects not even wanting to, because they just aren't aware where their body parts are. That's a huge thing. Balance deficits, falls, things like that, because of the decreased awareness of their own body. Poor core strength. A lot of them kind of have that hypotonia, that generalized weakness, and demonstrate for poor core strength, poor coordination, gait instability, frequent falls, decreased body unit awareness. We talked about poor proprioception. Most of the children that we saw, and I saw a lot of adults with autism as well, needed PT, OT, and speech. So OT worked on more on fine motor tasks and writing and, school types of activities, and grasping, and ADLs, brushing the teeth and things like that. Whereas PT would work more on the large motor, walking, stair training, walking on uneven surfaces. I would do a lot of obstacle courses, depending on what motivated the patient, because some weren't motivated to do that, and they might be motivated just to get a chance to play on the iPad or something like that. And so you would have them do this. If you do, some people with autism have very like concrete thinking, like you can tell them do 6 things and then you earn 1 minute on this or whatever. And sometimes that's really motivating. I had one guy with autism that was really motivated by having the highest score. So we were working on arm strength, and he would hold on to this ball and see how long we would time him. And he every time would want to beat his score. And he even had a picture of him up saying that he had the high score on the ball holds. He was the only one in the clinic that was doing that exercise, but he was so proud of himself, and that was motivating to him versus another. I had one that was really difficult to motivate. He only got motivated by squeezing Play-Doh. Like he loved Play-Doh and he would do anything to grab the Play-Doh and squeeze it. So I would set up an obstacle course and I would hold the Play-Doh in front of him and like lead him through the obstacle course, and he's like chasing after the Play-Doh, and then at the end he would get to sit and squeeze the Play-Doh. Um, and that was really motivating until Christmas when his mama bought him a lot of Play-Doh. And then he got to play with it all the time, and I could not find anything to motivate him anymore. But you have to find what works with that patient. And then speech therapists, they'll work on speaking, which is huge. If they're nonverbal, there are devices out there. They look kind of like an iPad, and you kind of you can pick pictures, and it can, say something for you, or you could type in if you're able to type in what you want to say, whole sentences, and it'll say it for you. Um, and there's pictures that already have sentences with them, like you can push the bathroom and it'll say, I need to use the restroom or something like that. And so teaching them how to do that, if they're nonverbal, that can be really helpful. But they also work on feeding activities and textures. I saw a lot of that. There was one guy that would, like I said, he would puke just at anything, the least anything touching his mouth. And they would work on getting his mouth less sensitive. So they would use vibration, they would use different textures in his mouth, and so that he could eat various things without getting sick. So speech therapists work on a lot more than just speech. They also work on some of the processing information, whether it's through written language or verbal. But that's really helpful. And you can sometimes co-treat with an OT or a speech therapist to really get good benefits. All right, Down syndrome, we mentioned earlier, it's also known as trisomy 21 because it is an extra chromosome on the 21st chromosome. There are genetic tests to determine Down syndrome, and often they're performed during pregnancy, so they may know before they even have the child. But some of the common signs of Down syndrome are common facial features, such as the epicanthal fold, so that's that fold of skin by the eye, a flat facial profile, so it's more flat right there at the nasal bridge, and sometimes even more flat the cheeks or the forehead, protruding tongue, low set ears, widespread eyes. And then those are just the facial features. Some of the other features, as far as across the body, they often have heart defects at birth. They may even have to have a heart surgery at birth. There may be some blockages in the intestines. The herniated umbilical cord, so like a protruding area there. Low tone in general, generalized weakness. A gap between the first and second toe is something that may be common. And then predisposition to leukemia, more likely to have leukemia. There's typically a cognitive delay. There's also a significant delay in meeting the motor milestones. The neck musculature is often more thick and more skin around there. And then other conditions of throughout the body related to Down syndrome, common with Down syndrome: gastrointestinal issues, gastric reflux, leukemia, we said, respiratory issues, Alzheimer's as they get older, celiac disease, that is the intolerance to gluten, and cardiac issues. So a lot of health issues that are associated with Down syndrome as well. Indications for PT. Why would we treat a patient with Down syndrome? Well, typically they have low tone, and that's typically what we are treating. Also, there's poor coordination, balance deficits, gait instability. So all the things that we've mentioned before. But we will do core strengthening, balance, endurance training, proprioception, body awareness, coordination, spatial awareness, all the things that we would do with autism and some of the other conditions we can also do for Down syndrome. Fetal alcohol syndrome. So this is when the baby is exposed to alcohol during in utero. So while the mom is pregnant, and it's diagnosed based on symptoms. There's not a genetic test. There's often, but you can sometimes, you might see them go through withdrawals. They might be going through withdrawals after birth, but otherwise, now there are some tests that can determine if there's other substances in their systems like cocaine or methamphetamine. That can be done through infant screening. But only if those substances were used close to the time of delivery. So let's say the first half of the pregnancy, they're on a substance, but then they stop. It's not going to be detected in the baby, but that first half of pregnancy is when a lot of development happens, especially brain development. And so it may still have a significant impact. And typically with alcohol, it's the same way. Drinking early on during the pregnancy can cause the greatest detriments because that's when a lot of the development is occurring. So symptoms of fetal alcohol syndrome, they'll have facial features that are similar to those seen with Down syndrome, and we call those mongoloid features. But facial features, microcephaly, so a small head, low birth weight oftentimes, poor coordination, it might be hyperactive and impulsive, poor memory, poor attention, and they're often born premature. I have my brother-in-law's parents have adopted several children with different disabilities, and so they, I think all three of them were cocaine. Had cocaine in their system at birth, but only two of them had alcohol, fetal alcohol syndrome, and the one that did not have fetal alcohol syndrome, although he had cocaine, really had significantly less ailments and issues than the ones that had alcohol in the system. So it's amazing how alcohol really can be detrimental during a pregnancy. Indications for PT, basically the same things as before: coordination, balance training, spatial awareness, all the things that we've mentioned over and over will also be needed with someone who has fetal alcohol syndrome. One of the most common things that I started seeing that is really amazing is the agenesis of the corpus callosum. So the corpus callosum connects both sides of the brain. It's kind of that bridge. And agenesis means it did not develop. There's no connection between the two sides of the brain. It could be underdeveloped or it could be completely absent. And it's diagnosed by brain imaging. And I know in the book it mentions that it's rare, but it's becoming a lot more frequent because I had several patients with this. And I know they had mentioned their doctor said it's becoming more and more frequent, but sometimes it's missed because it's not common to do MRIs at birth or anything. Usually it might be caught as they're trying to determine if the child is having seizures or, if there's something else going on. So some of the symptoms are poor coordination, difficulty with bimanual tasks. So anything with coordinating both sides of the body is going to be difficult because there's not that connection between the sides of the body. Can cause gait and balance deficits, difficulty following instructions. You say move this way and they really have trouble moving that way because the brain is not connecting those pathways. A lot of the same issues with hypotonia, the generalized weakness, and then motor milestone delays. And we will do basically the same types of treatment as before, but also more focus on crossing midline and on bimanual tasks. So on doing things with both arms together and on crossing over, because that can help develop new connections between the brain. I had one patient that had, well, I had a lot with agenesis of the corpus callosum, but one that had agenesis and he had, uh, you know, it's not surprising he didn't have a corpus callosum because he didn't have a whole left hemisphere of his brain. He only had one half of the brain, and that side was underdeveloped. So he had very little brain matter. And whenever his mom was pregnant, they saw that and they recommended her get an abortion, and she didn't. And amazingly, this guy, they didn't think he would survive. Not only did he survive, I mean, he could walk, he could talk. He had therapy from the time he was tiny. He could feed himself. I mean, he displayed like a child with cerebral palsy. He had one side of his body that had weakness and a little bit of tone. But even that, I mean, it was amazing what this little guy can do. And it's just amazing the miracles that we can see with our own eyes on, a child that had not even half of the brain developed. Um, and what that would be called is anencephaly. So anencephaly is a congenital defect where a baby is born without part of the brain. It could be a significant part of the brain. It could even be part of the skull. So here, as you see, he's missing most of the top portion of his head because the brain is completely underdeveloped and the skull is not even developed there. It's often diagnosed in pregnancy, and typically, if they see it in pregnancy, they're going to recommend an abortion. The baby if there's not an abortion, the um, mom may miscarry, or the baby may be born as a stillborn as well. So that's one of the reasons they may recommend that is because they're not sure that they can survive. But as you see, this baby survived. I saw something about this little one surviving at least to his first birthday. I saw an article about that. But it's really, it's a hard condition. Um, it's visible with imaging, and then some you can see with the naked eye. And this is a type of neural tube defect. So just like the spina bifida, this is a type of neural tube defect. Symptoms, it may cause a miscarriage or a stillborn. And most, if they have significant anencephaly, will only survive a few hours or days if they do survive. But there are always babies that beat those odds. So if they do survive, they may have significant delays. And then again, they may be a miracle baby and not. So you never know. And then hydrocephaly, that's cerebral spinal fluid on the brain when there's increased amount of fluid and it causes significant swelling. It could be from an overproduction, poor absorption, or an obstruction. So those are some of the reasons the cerebrospinal fluid will build up in the brain. It enlarges the ventricles and it puts pressure on the surrounding brain matter. If it's not drained quickly or relieved quickly, then it can cause brain damage to those areas. Most of the time, they will go in and put in this VP shunt. So it's a ventriculoperitoneal shunt. It goes from the ventriculars inside the brain down into the abdominal cavity to drain, and it just drains fluid from those ventricles down into the abdomen. The shunt typically stays in there their entire life. It's diagnosed by brain imaging, and of course, you can see sometimes visually if a child has it. Now, you have to be really careful and monitor that shunt because if they have any signs, we'll go over the signs of hydrocephaly, but if they have any continued signs of hydrocephaly after the shunt has been put in, then the shunt needs to be checked because maybe it's clogged or blocked, which would then require immediate medical attention. An enlarged head, the bulging soft spot or fontanelle at the top of the head, vomiting, seizures, the eyes fixed in a downward position, low tone, irritability, difficulty sleeping and eating, decreased response to touch, poor growth. All these are signs of hydrocephaly. And if they have the shunt and they're doing better and then they start to backslide, immediately they need to go have the shunt checked just to make sure that, nothing's going on there. I didn't have any patients that actively still had the, hydrocephaly that you could see or anything, but I had a lot of patients that had the VP shunt. That's a pretty common procedure to decrease this, at least in this country it is. And so I had quite a few that had a VP shunt, and you had to be a little bit careful monitoring them. Treatment consideration, and avoid increasing their intracranial pressure. So we do not want to increase the pressure in the brain. So you have to be careful what you do. You don't want to be having them hang upside down or do the Trendelenburg position, or even, bearing down really hard to pick up something heavy or anything like that, overstraining, because that can increase the intracranial pressure. Avoid over fatiguing. Watch for signs of malfunction. So if their head starts to grow or the soft spot starts to bulge, if they have a cognitive decline, vomiting, or seizures, then they certainly need to be checked for the shunt performing correctly. And then make sure you're doing low impact exercises and increase in recovery time so that they do not overwork. I know this was a long lecture, and I appreciate you sticking with me through it. And if you all have questions, please let me know. Otherwise, I will see you in lab tomorrow.